Conventional medicine versus functional medicine. That is today's topic, specifically looking at which model provides the best health, economic, and quality of life outcomes over a lifetime. I don't want to give a message saying that I think one is better than another for a specific moment because both have a role. Conventional medicine is great for life-saving and tumor, fracture, hemorrhage, emergency medicine. Functional medicine is not good for that. Functional medicine shines in quality of life, health span, preventing chronic disease. Conventional medicine is terrible at that. So they both have their own uh, areas where they shine, and they're both needed at the right time. But in terms of a paradigm that a person, a community, a nation, a world should function under, that's what we want to look at here is what would provide uh, the healthiest humans, the healthiest uh, macro or micro economies, and the best quality of life. So, what we're going to use for our support today is this paper that was published recently in Global Advances in Integrative Medicine and Health, entitled Making a Case for Whole Person Health. And this is really an interesting thought experiment by these authors where they're comparing conventional medicine to what they call whole person health. I would call it functional medicine. In an imaginary patient age 40 and following her to age 80 down both paths. And so if we dive into this paper, I'm going to break down the details for you on how they did it, and then we'll actually go into the case study. So we're going to jump over to the paper quickly and come back to the PowerPoint after that. All right, so here we are on the paper, and if we look, if we zoom in here, what this, what this, what these authors were looking to do was the background for the study is our conventional approach to healthcare tends to separate patients' health by body system, treating each independently and quote unquote efficiently, meaning minimal time with a provider, relying on medications, and little investment to support behavior and lifestyle improvements. So it's basically, hey, in America, it's you have an average of 7 minutes with your doctor. Their goal is to get your symptoms, match you with a medication, get you out the door. Okay, so it's not really about health. It's um, you know, giving you the best palliative symptom relief care and getting you out the door and continuing down the McMedicine conveyor belt. Okay. Meanwhile, by practicing that, this paper says the United States has the most expensive healthcare in the world with some of the worst outcomes. The purpose of this paper is to make a case for transforming healthcare from a disease centric approach to a whole person model. How are they going to do that? We provide detailed health and healthcare utilization assumptions for a hypothetical patient, Mrs. M, over her life from age 40 to 80 years under both care scenarios. Version A is continuing down conventional care like the typical American gets, and version B is the whole person care approach or a functional medicine approach, is what I would call it. And in order to, they developed a set of healthcare utilization assumptions for each scenario, applied the 2023 US dollar resource prices, and estimated total cumulative healthcare costs across their little experiment. So if we go down here, there's quickly, despite having the highest per capita investment in healthcare in the world, the United States has alarmingly poor health outcomes, and this situation is getting worse. An important and largely overlooked problem is our focus on treating diseases separately once they occur, rather than making the upfront investment needed to maintain and restore the health of the whole person. Whole person health refers to the idea that every individual's location on the health disease continuum is the product of broad interconnectivity, both within and across biological systems, health behaviors, social connectedness, and environmental factors. What's that sound like? Functional medicine, right? Each person is a puzzle, and the puzzle is made up of a bunch of pieces, including their genetics, their biology, their behaviors, their social connectedness, family, friends, purpose, right? And then environmental factors, toxins, molds, sunlight, etc. So everything matters. And so if everything matters, why aren't we treating someone like that? There is a need to recalibrate our healthcare system toward a more integrated whole person perspective. Our global health crisis underscores the importance of approaching health from the whole person perspective. We use an illustrative hypothetical clinical case study to demonstrate the transformative impact that whole person care could have on the US healthcare economy, as well as the well being of patients. So, again, what they're doing is they're going to describe this hypothetical 40-year-old female who serves as a starting point for the two paths. One's going to follow conventional care, one's going to follow whole person. Both paths will follow her until she's 80 years old and are built on underlying details about the patient's likely health and healthcare utilization for each year. How did they estimate the costs? Well, the two were contrasted. The conventional model is the more reactive, disease-oriented, fragmented care approach that's characterized by a greater number of specialist visits, diagnostic testing, prescription medications, and other treatment interventions. The whole person approach is integrated health promoting approach characterized by being more proactive, holistic, skills-based interventions tailored to the individual. The details on healthcare utilization and unit costs underlying the two paths were laid out by a primary care provider with experience in both scenarios, and then they had an independent second primary care provider with experience in both scenarios validate that these were costs and utilizations that were accurate and realistic. Both providers were asked to use their best professional judgment to identify average health complaints, treatment options, and outcomes in both trajectories. All health-related diagnostics and treatments outlined in this paper were consistent with current U.S. clinical guidelines, and as were the prescription drugs. The whole person care scenario incorporated several evidence-based non-pharmacologic interventions emphasizing health promotion and symptom self-management, including cognitive behavioral therapy, deep breathing techniques, physiotherapy, health coaching, nutrition, etc. And the costs for each path were valued for each year using the same set of 2023 unit costs. All right, so let's look at the case study. So let's jump back to the slides here. All right, so here we are at the case study. So we'll start with Mrs. M, and we'll start with her at age 40. This is her 40th birthday, and she's at a decision point. She's been using conventional medicine up to this point in her life, and at present, she's been diagnosed with hypertension and is on the hydrochlorothiazide medication for it. And she's also been diagnosed with knee osteoarthritis and is on ibuprofen and acetaminophen for that. She's also seeking help for persistent insomnia or sleep problems, heartburn, and weight gain. Her symptoms are common in this age group and indicate the involvement of several different body systems, which are often each treated separately in the conventional care model. We'll follow her for the next 40 years from this point forward and examine her health and healthcare utilization as she experiences each of the two alternate care paths. So we'll begin with path A, which is the conventional care scenario. So let's follow Mrs. M. In this scenario, Mrs. M continues under conventional care. At age 41, her blood pressure remains elevated, and she is started on an angiotensin-converting enzyme inhibitor, lisinopril, in addition to the hydrochlorothiazide, which is the water pill. Although she was advised to lose weight at age 40, her BMI, or body mass index, has increased from 28 to 30 in the past year, and her recent fasting blood sugars and hemoglobin A1C have been slightly elevated. So she's progressing from just high blood pressure and pain to high blood pressure, pain with weight gain that promotes an insulin resistance type 2 diabetes bias. As efforts to improve her diet have been unsuccessful, she was started on metformin. Okay, there's to help deal with the blood sugar. At age 45, she underwent an upper endoscopy. So let's see her at age 45. At age 45, she underwent an upper endoscopy, was diagnosed with GERD, and was started on omeprazole. She was also prescribed temazepam for sleep, so she's now on a total of 6 medications. The figure also illustrates how each of her medical problems is being treated separately. right? So she's not Mrs. M in the conventional doctor's office. She's whatever symptoms. So for the cardiologist, she's hypertension. For the gastroenterologist, she's gastric reflux. For the endocrinologist, she's type 2 diabetes. For the GP, she might be osteoarthritis. Uh, and then the anxiety and insomnia might be her psychiatrist. Okay, so she's seen 5 different doctors for 5 different complaints. 35 years later, at age 80, Mrs. M is in a nursing home. Her hypertension and diabetes are under reasonable control, but her insomnia and chronic knee pain are increasingly problematic. She has not been able to sleep without medication for many years. She's had some significant cognitive decline, daytime somnolence, unsteady gait, several falls, and worsening anxiety. She had a gastrointestinal bleed from erosive gastritis in her mid 60s and can no longer take NSAID medications like ibuprofen and acetaminophen. Excuse me, as ibuprofen. And she needs occasional opiates for her knee pain. So this is the progression down the conventional model. And I'm sure everyone watching or listening to this knows someone, in their late 70s or 80s that this could be an avatar of. They just keep collecting medications and then have more symptoms. So they're taking medications for side effects of medications, and it all stacks up. And as we've spoken on previous videos, the health span declines, the disability increases, and you end up in a nursing home, which is going to have many costs along with it. Let's look at Mrs. M from version B. In version B, starting at age 40, Mrs. M's care team starts by exploring possible connections between organs and systems, as well as across biology, behavior, social interaction, and environmental domains. Upon further questioning, Mrs. M reports that her neighborhood has become increasingly noisy and unsafe, which adversely affects her sleep. Ooh, so rather than giving her a sleep medication, maybe she should move, right? There's a thought outside the box. She notices that her blood pressure and heartburn are worse when she's not sleeping well. Well, of course, many things are worse when you're not sleeping well, as we've discussed in previous videos. Research shows that just one night of 5 hours or less of sleep increases inflammation, decreases insulin sensitivity, and interferes with circadian rhythm function. So, raising cortisol and less recovery, raising blood pressure, anxiety, etc. So, sleep is key. And if you lose sleep, blood pressure might go up, heartburn, etc. She works as a receptionist at an urgent care clinic and has had to work extra shifts due to staff shortages. So that could impact her sleep, but also her stress, right? She doesn't have the free time or the social interaction that she's used to when there aren't staff shortages. Her work is mostly sedentary, and although she used to go walking in a nearby park, recent construction made the sidewalk unusable and she stopped going. So that's just going to add to the stress, to the weight gain, to the pain, to the poor blood sugar. She has gained weight in the last 5 years and feels the lack of exercise has contributed to her weight gain and worsening knee pain. Her diet consists of mainly what she can grab quickly at work or on the drive home. There are no grocery stores selling fresh fruits and vegetables within a convenient distance of her home. After Mrs. M's initial evaluation, she was referred to a health coach who instructed her on using an app for cognitive behavioral therapy and breathing exercise to help her sleep. She noticed that the abdominal breathing exercises helped with her heartburn as well as her sleep. At age 41, she was referred to a physical therapist for her knee pain and was able to increase her walking time using a fitness tracking watch for motivation, and she was able to discontinue her prescription ibuprofen and acetaminophen. Ooh, that might prevent that GI bleed in her 60s, getting off those meds. The following year, at age 42, she was referred to a dietitian for nutritional counseling and to a social worker who helped her sign up for a home food delivery program. With more energy due to her improved sleep, she's more motivated to start cooking meals which she enjoys. Her weight stabilized and her blood sugar began to trend down, instead of up on the other path. Her successful behavior change was facilitated by a personalized approach, starting with what mattered most to her, wanting to improve her sleep, and gradually incorporating additional elements of physical activity and diet. She remained on only one medication, her blood pressure medication. So at 45, you can see importantly that the lifetime habits and stress management skills that she acquired from age 40 to 45 will be relevant for the rest of her life, allowing her to play a more active role in her health journey and contributing to a healthy aging process. Now we can fast forward 35 years to age 80. Mrs. M has been living at her daughter's home for the last 10 years. She remains physically active and helps care for her grandchildren, which she describes as adding meaning and purpose to her life. She continues to take the water pill for her blood pressure, and this remains her only medication at age 80. Look at version A, how many that version is on. Okay. She eats mostly home cooked food and her weight and blood sugar have been stable. Her knee continues to bother her, mainly going up and down stairs, but she says the pain is manageable. She describes her overall health as good and is satisfied with her life. So look at those two paths from a health and quality of life standpoint. It's right there in front of us, right? Sometimes you need a medication, and just being on one medication at age 80 again would make her a unicorn because the average 80-year-old in the US is on 7 to 9 meds. Okay, so that's big time health improvement if that's all she did. But then also becoming educated on how to eat better and sleep better and exercise, and then having the social interaction, living in a multi-generational home and having purpose to help raise her grandkids. The health span or the quality of life is massively improved, not only because she's not disabled, but also because she still has a purpose, feels important, and is living with family and loved ones. So there's the health and quality of life part of that. If we also compare the utilization between the two scenarios, you can see in this table a big difference. So if we go and look at number of medications over the 40-year interval from age 40 to age 80, okay, if you look at conventional care, the way that these authors measured it was this is how many medications a year, okay? And so this is across the years, if you add up all the years, how many medications were they on yearly? The version A was on 275 medications versus 41 for the version B. So basically, she was on one medication for 40 years. So there's 41 years worth of medication. The version A person in conventional care was on 275 medication years of meds. Not good. What does that lead to? Well, that leads to more specialist visits because the medications aren't making her healthier, right? They're just hopefully reducing symptoms. But reducing symptoms and leaving the cause leads to the cause getting worse and potentially bleeding over into other systems and other causes, which requires more specialist visits so they can give you more medications, but you don't get better. Whereas the whole person care, she had one specialist visit in 40 years. Looking at urgent care and emergency department visits, the version A, conventional medical care, she had 47 visits to urgent care over the 40 years. The whole person had 18 over the 40 years. And then the hospital days over the 40-year period, the conventional medicine, Mrs. M spent 8 days in the hospital. She spent no days in the hospital over the whole person care in 40 years. That's huge. Other visits. The other visits, she had 199. What could those be? Well, that's all the lifestyle and really health focused clinicians that she saw. So there's the nutritionist, the dietitian, the cognitive behavioral therapist, the social worker, etc. Okay, but those visits led to low numbers across the rest of this. So those visits are okay. So that's utilization. If you're utilizing, then you're also spending, right? So if we look at the whole 40-year period on both pathways like this, you can decide for yourself which path you would prefer. And there's some interesting information in this graphic. There's the obvious, which is, hey, we'd rather be path B, right? And get to our 80s with a high sense of well-being with maximal independence and being healthy and active. None of us want to be this, except this is the model that we're all herded into. This is the reactive model, and this is where you're going to be if you don't take action. To be this way, we must be proactive. Okay. Now, another thing that drives people this way is we're brainwashed into thinking that we shouldn't have to pay for our health care, right? Use your insurance. Insurance will cover it. Medicare, save for Medicare. Once you hit 65, it's all good, all that stuff. Not true. Okay. You're going to have to pay one way or the other. In this case, yeah, maybe you're not paying as much out of pocket, but you're paying for lost quality of life and lost lifespan. This one, you're going to pay more out of pocket initially. In the first 5 years, it's actually more money to do the proactive care. Okay, because you're going to see more doctors in the first 5 years or more clinicians because you're using that nutritionist and the cognitive behavioral therapy and the exercise person and all of that, right? But once you invest that money in the first 5 years and once you learn the lifestyle that works for you, now you still have visits over time, but you're empowered to do most of it yourself the rest of the way. So now your expenditures stay flat. And over 80 years, you're spending less than $1,000 a year. Whereas going the conventional route is cheaper the first 5 years, but then much more as you go, especially when you hit age 75 and up, because that's when you enter the nursing home, and the nursing homes are very expensive. So the cost just is the difference is huge. And you could say, okay, say this was too conservative. Okay, double it. It's still only a third of this. So being proactive, learning how to take care of yourself is going to provide everything you want. Better money for you, better long-term health, better quality of life. And so it is an investment, but anything worth having is worth investing in, right? And so the authors conclude, indeed, from age 40 to 50, healthcare costs were nearly the same for Mrs. M under both scenarios and were even slightly higher for whole person care from age 40 to 43. After age 50, however, healthcare spending for the whole person scenario remained essentially flat, while spending under conventional care climbed steadily, accelerating after age 75 when skilled nursing facility was required. This illustrates how an investment beginning in early middle age to support a healthy diet, physical activity, and stress management can not only lead to improved health and well-being, but also reduce healthcare spending over the remaining lifespan. Our findings show long-term expenditures to be substantially lower than the conventional care model, due largely to avoiding costly care associated with disease progression, development of other comorbidities, and adverse events. Moreover, given the better mental and physical health outcomes, the whole person care model could reasonably be expected to result in a greater number of years lived without disability. So, in conclusion, a whole person biopsychosocial health model beginning at age 40 could plausibly result in substantial healthcare savings over the following 4 decades. Adopting a whole person approach to health even earlier in life could be expected to result in even more meaningful impacts on health and healthcare costs. In our model, although support for lifestyle and behavioral interventions cost money initially, these costs were more than offset by a reduction in healthcare spending in later years. So if you would like to embark on version B, if you want to be the Mrs. M that is still independent and helping raise her grandkids and loving life at age 80, or Mr. B, then functional medicine, a whole person approach, individualized and specific care is the key for you to achieve that goal. Let's open it up for questions or comments.
I have a comment.
Yeah.
Because if I had not started with you 4.5 years ago, I would be way worse than that plan A, way worse. Because I had all of that stuff. And then if you add in an autoimmune disease, it's even worse. So grateful that you brought this to light. This is amazing.
Yeah, you're welcome. Thanks for the comments. Yeah, I mean, this is the path, right? Version A is the path for everybody, unless they choose different. Um, And so part of it is they have to know there's different to choose, and that's part of the, my efforts for with the YouTube channel and the book, and obviously getting results with patients who then spread the word and refer. But yeah, it's unless we choose differently and kind of buck the trend or go against the crowd, how are we gonna get a different result? You won't unless we choose different. So props to everyone here for choosing different because you're on the call because you chose different. And then anyone who's not on the call but watching this later, you can choose at any time, right? The cool thing is that the body wants to heal and can always get better once you figure out what it needs and what it doesn't need and do the right thing. So even if you didn't see this till you were 61, say, you can still start to take the actions to reverse whatever, wherever you are on the continuum or improve it towards version B.